Thank you very much, Mr. Chairman. Good afternoon to everybody. Thank you for your kind invitation again to this fantastic meeting. So my topic is difficult crural lesion tips and tricks for endovascular management, and this is my disclosure. So for sure, the first problem we have approaching patient with critical limb thickening ischemia in the leg is to cross the lesion. If we do not cross the lesion, we cannot treat the patient. So this is the first postulate we have. So the problem we have to manage very often approaching this patient who are really difficult and very often are complex patients because they are diabetics with a history of dialysis or prolonged use of corticosteroid drugs is the grade of calcification. So the main problem I discussed with some of you yesterday, for example, is how can I get a balloon or something when I succeeded in crossing the lesion with my wire. So actually, when we have the wire distally into the lesion, it's really frustrating do not succeed in crossing the lesion with a device. So we have some technique, some tips and tricks to help this situation. The first one is improving the support with the long sheet. The second one is try to use what the Japanese call the bad manner technique. The other one is the piercing technique, inner or outer technique, and the last one is the direct extravascular cracking. Speaking about the long sheet, we can use this to improve the support. For example, in this case, we have a short occlusion that's severely calcified. You can see here a short balloon with a single marker, so very low profile, cannot cross the lesion, and when we push the wire, all the artery is deformed by the strength we apply. So in this case, we can use a long sheet. We insert a second wire to arrive with the long sheet directly into the lesion. Sorry, the video, of course, has jumped directly into the tibial vessel with the long sheet. And when we have the long sheet in position, it's not possible to do this. When we have the long sheet in position, we can improve really the crossing capability and the power of our balloon, and we finally, in the most of cases, we can succeed in crossing and dilate with, in this case, with 26 atmospheres, the lesion in order to achieve an acute good result. Of course, we may have the same problem much more distally. So in this case, you can see the same situation. A short balloon, single marker, cannot cross the severely calcified distal anterior tibial very close to the joint level. So in this case, we could try to use the bed form technique. Bed form technique, it consists in trying to perform a retrograde distal puncture, snaring the wire directly into the needle, and in order to externalize the wire out of the body of the patient. When we have in our hand the wire, we can fix a torquer device directly against the cone of the balloon. Exactly, you can see here the cone fixed in proximity of the cone of the balloon in position, and after this it's enough to pull the wire, and we pull the balloon together. You can see here the advancement of the balloon finally out of the body. We will destroy the balloon, but we deuterize the lesion. We can easily pass the next balloon, and we can use and we can finally treat this stricture. So, of course, we have to learn how to cross, and normally we use the concept of the wire escalation and de-escalation concept. So when we have, again, a severe occlusion calcified in the distality of this anterior tibial artery, we normally use the step-by-step increase in the power of the wire. So we can start with the workhorse wire, and we could arrive up to the most powerful wire as the 30-gram wire. You can see here how at the end of a prolonged series of attempts we could cross this lesion with a 30-gram Astato wire from Asahi. Then, of course, when we are in the proximity of the lesion, we have to try to destroy the calcium with the direct puncture. We use a big needle, normally it could be a 16 gauge or 18 gauge needle, and we try to crack the calcification directly with the tip of the needle, and at the end we will succeed in crossing the lesion with the balloon. After you can see the balloon pass the lesion, we can inflate the balloon, predilate the lesion, and treat the lesion as we want to treat with modern technology. For example, this technique was published by Tomoyasu Sato, interventional radiologist from Hiroshima, and you can see here after the predilatation and after the treatment with drug-eluting balloon, the final result with a very nice flow into the foot in this patient. So another kind of piercing, what the Japanese recently published, this technique called the inner piercing. So again, they use to retrograde puncture to snare the wire, as I showed you before, and when they have the wire out, they insert a long 21 gauge needle, and they rotate the needle inside the artery in order to debulk, destroy, and cracking the plaque from below to the upper part. And again, this technique, which is probably much more aggressive and a little bit more complicated, could be really helpful and could improve the amount of success in our practice. The last technique in the hand of vascular surgeons is really efficient. Is from my friend Stephen Coombe, vascular surgeon in Singapore. He performed an incision in the skin directly in correspondence of the occlusion, and destroys directly with the surgical instruments the plaque, of course, with the wire inside, and after this direct crack it's possible to advance a balloon. This is a case, but I don't think we have time to see the entire case about, of course, a below-the-knee procedure. This is the CO2 angiography showing stupid problems in SFA and popliteal tract, and of course below the knee the situation is really different. The flow is very bad, and again, in proximity of the joint, you can see the very short and apparently stupid occlusion of the anterior tibial artery with a landing zone in the foot. You can see here the lateral view of the foot. The flow is really compromised there, so I decided to aggressively approach. I can show, this is the anteroposterior view of the foot. Of course, we treat all the lesion in the inflow, and then we approach the distality. You can see there is again a short occlusion, and we start to be aggressive. This is a 𝗏𝘀𝗰𝗂𝗀𝗏𝗀 from Boston with 20 grams in the tip after the first workhorse wire, and you can see how the manipulation of the wire tends to remain exactly in the middle of the calcification. It's very important to try to keep our tip straight and never do a loop in this case, because we can damage the wire, of course, but we can have an unwilled dissection in the vessel, and we may have a worsening situation after this. So you can see here we increase the power of the wire. After the 20 grams we use the 30 grams, and again I cannot jump in the video because otherwise we do not have time to show everything. Okay, so again, finally we could arrive in the distality with the 30 grams, and now we have to de-escalate the wire. So from a high power wire we have to run and try to navigate the distality. So we have to decrease the power of the wire, and we use now a Fielder FC wire in order to remain in the terlumen. And when we are here again, we have to try to I can do me and technique. Two different things. So again, you can see the aggressive piercing, the aggressive attempt to destroy the calcification. Finally, the balloon can pass. You can treat the, may I show the conclusion, please? Just 2 seconds to say hello. Okay, thank you. So, next, come on, believe me, we can do. No, next. Okay, so in conclusion, for sure advanced BTK and BTA procedures are complex, in particular for calcification, because of dialysis and diabetes together. Crossing is mandatory to deliver any therapeutic option we have, and so we have to consider these techniques to improve your success rate. The first postulate is, of course, never give up. The wire escalation concept, according with the anatomy and the amount of calcium, is really important. The first, try first with simple solution like the long sheet, and of course remember that you may have severe bleeding, has been reported in the original paper of Pierce. So in the distality is quite safe, but in SFA could be dangerous. Thank you very much.